So basically, you have seen that over the last few years, there have been a tremendous evolution of the digital technologies. This weekend, you're going to be exposed to so many world-class presentations, and you're going to see different people showing you how to come across these technologies and how to implement these technologies in your practice. Basically, that's what I'm going to try to do today, because in the process of evolving in computer-guided surgery, we now have different ways to address this type of technologies in so many different manners. And as these technologies are being developed, it becomes confusing and it's hard to look for directions. So what we would like to call today the digital revolution is something that has been adopted by so many labs, so many companies, so many universities, so many practices, and I'm sure that many of you already are totally immersed into this digital revolution, and also many of you are making considerations in what technology to acquire for your practices and how to especially incorporate these technologies in your own personal universe. So this is about how I have been able to incorporate it in my practice. I am a clinician. I had retired now from my permanent teaching position in the Florida universities, and now I'm totally in my practice, and when I lecture, I'm lecturing in clinical related stuff. I have been lucky that from the very beginning of my career, I got exposed to digital dentistry, working at Tufts University in the development of many of the technologies that you see today, and I happen to have big trees giving me good shadows. So, as I said before, anytime that you think about the digital revolution, the first thing that you have to think is about the digital flow. And the digital flow starts with your consideration of generating whether a cone-beam CT or an optical scan with one of the intraoral or extraoral scanners. And with that data, you need to have a purpose in mind. And usually, the first thing that you do is that you export that data into a software, usually a design or an interactive software, with the purpose of doing some planning, doing probably some milling, or doing some printing. The most important thing in all the considerations that you have in this aspect is acquire friendly softwares. Software that are not going to be overheating your brain, software that are not going to make you hate these new toys that you are getting into your practice. If you are taking something home today, this is what you are taking home. And I keep on showing this slide. Digital implant dentistry is based on a process of correlation and transfer between the virtual world, which is your computer, and your clinical setting. If you have this super clear and you're able to mentally travel from one world to the other, 90% of the problem is already resolved. And you're going to see this statement all over the lecture. This digital revolution is not new. Don't think that you're being exposed to new stuff. You're going to see that as I show you the technologies, you're going to see that these technologies have almost 2 decades, 3 decades, 4 decades. And started with the work of Godfrey Hounsfield creating the medical scan, then with the theoretical work of François Duret in France when he did his thesis to obtain his dental degree, and he created a theoretical approach to optical scanning, which was then adopted by Morman and Brandestini, creating practical optical scanning, computer-assisted design, and computer-assisted milling. They invented the SEREX, and that was the beginning of the hands-on work and the incorporation of these technologies in our dental practices. And we have seen all over these years how these intraoral scanners have been evolving, getting faster, getting more precise, getting easier to utilize, getting more friendly. We have seen the milling machines evolving. We have seen the 3D printers, so many different cone-beam CT machines now in the market. In the beginning, there were 1 or 2 only, and now so many wonderful and fantastic interactive softwares that are getting also easier to use and easier to incorporate in our practices. So remember the original statement that digital implant dentistry is based on a process of correlation and transfer between the virtual world and clinical setting. Keep it in mind, because that's, again, the end of the game. When Mr. Chuck Hall in 1984 created the STL format, he gave us the opportunity to communicate in the same language. Because again, I'm Latin, I'm from Colombia, my original language is Spanish, and I'm communicating with you in a terrible English that hopefully you're being able to understand. So STL did the same. You got a machine that was made by one company, now communicating with a machine that is made by a different companies. And utilizing these 3D formats, the different machines can now accept files, share files, export files, and be able to utilize information from different aspects. And this was something that happened within the last 10 years. And we call that open architecture. The open architecture basically gives you the opportunity to communicate different machines. There are other machines that have closed architecture, basically means they only speak one language. So basically, the origins in our practice in computer guided surgery started with incorporating the technologies that you guys are already familiar with, deciding that convincity would be generated for a specific patient. We had to go through the process of planning and diagnosis, risk management of the patient, 3D reconstruction. Then originally we would get into cleaning by hand all these images that sometimes would have a lot of artifacts, and we would have to go into a process called segmentation, which was basically manually cleaning all this info. And from there, we would go ahead and do the planning of our implants, our virtual crowns, our abutments, and some of the anatomical structures. And we actually got pretty good at it, and it was almost an artistic type of work. But then we were able to incorporate optical impression, optical scanning, and we were able to communicate these interactive softwares with these technologies to utilize this for planning and for diagnosis in the cases that we were doing. So we were able to look at the interocclusal spaces, the ideal positions to place our implants, angulations, size of the crowns, height of these crowns, and start what we like to call perioprosthetic treatment plan, because it's cheap now to plan a case with a prosthetic end result in mind and not keep in mind the soft tissues. So now prosthetic end result is not enough. Soft tissues and prosthetics go together hand by hand. So once we were happy with the plan, we would generate a guide. This guide would usually be created by a company. Today you can make these guides in your own practice, and we, in this case, we're utilizing one of the companies available. We have utilized pretty much all the available companies. Usually these companies send you indications so you can follow the different steps for the different bursts that you are utilizing. You check the fit and the stability of the guide, and you proceed to perform the sequential osteotomy. It's always good to go slow and to be double checking. We like to do intraoperative x-rays. Do the sequence carefully. Utilize bursts that have vertical stops. You can work minimally invasively, or sometimes you have to open flaps and do major reconstructive work, because you have to change the structures of the bone in the operative area, in the surgical area. And one thing that we always like to do is we like to work redundantly. So we like to not only work digitally, but we keep on utilizing the same normal analogs to take impressions and keep them as a backup. In this case, for example, we decided to immediate load utilizing one of the common machines that we find in the market, and we follow the normal process of preparing an abutment. Sometimes we can pre-prepare an abutment. In this case, we prepare the abutment on set. We utilize an intraoral camera. There are excellent intraoral cameras now available. You have the tree shape outside, for example. What we are doing in our practice today is we're bringing a virtual lab technician. I'm not doing the SEREC myself. I'm not doing the intraoral scanning myself. I'm bringing somebody that is the whole day scanning and designing and milling, and we bring this person to expedite our work. And I strongly advise you to prepare somebody in your practice that you can trust, that have knowledge. Raymond is a Mexican dentist that works in Miami as a virtual assistant, and is one of the persons that we like to work with because the guy is very knowledgeable, very dedicated, and very proud of his work. We go through the milling process, and we don't only use SEREC. We utilize probably 7 different types of milling machines. They work pretty well. And one of the reasons why I like to bring this guy on is because when you work with this type of technologies, yes, you're going to get a crown that is going to fit. You're going to get a crown that is going to have whatever anatomy that you have virtually designed. But one of the big problems is that what takes the longest time is to get into adjusting the different shades and the different colors to get good cosmetics, to make these ceramics look good. And that can take you a full afternoon just adjusting the colors. And really, it defeats the whole purpose of milling in your own practice. So the firing, the glaze, the stain, the crystallization of an IMAX crown is a process that takes time, takes expertise, and it's good to have somebody working on it while you are doing some other work. So we go through that process, and this is kind of the type of work that we can develop in our practice, utilizing the available technologies, a patient that goes home very happy. So this is about where we are right now in computer-guided surgery, the classic approach that we have been taking. But there's now another option. The other option is to work with dynamic guided surgery, what is called now real-time navigation. There are now several machines available. Naviden happens to be one of these machines. And the first thing that we need to do about this technology is to understand how it works. This technology is pretty much similar to the way that the GPS tracking technology works. We know that we have satellites in the space tracking our cars, which have GPS units, and the lamp of these devices are doing the same, are tracking our bird, are tracking the head of the patient, and are overimposing our Convincity machine with the 3D environment, just like the GPS technology is doing with the map when you are navigating a boat or you are navigating a plane or a car. So this is the machine, and most of the machine available are composed by a camera box, by a boom arm, by a computer, and by a card. And all these machines also have these tracking devices, which happen to be different from machine to machine, and there is also another tracking device that is installed in the mandible of the patient. A lot of literature have been now developed, and it's been available now for the last 17 years pretty much, and the technology of these new devices are pretty impressive. Once you develop the idea of situating yourself in the three-dimensional environment, you are super, super precise. It takes some time, it takes some practice, it can get discouraging and frustrating, but if you keep on working on it, at some point you develop a feeling and you work by feeling pretty much, and it just flows like it flows when you freehand your work in your practice doing any of the other techniques. This technology is not new. This is the original technology, RoboDent. I believe it was originally developed in Germany, and some people in the USA were the early adopters of this technology. And when you look at it, it looks super similar to the technology that we have today. It's exactly the same pretty much. Many articles were developed between 2002 and 2007. Bob Miller in Florida was one of the early adopters of the technology. But what really was incredible was when I was looking at these people back in 2000 were already utilizing the barium sulfate acrylic teeth and doing all these scanning appliances to try to get an idea of the prosthetic position to have a prosthetic end result. They were also having virtual implants already, and they were also being able to trace some of the anatomical structures. And that is very impressive because many of us started to get exposed to computer-guided surgery and interactive softwares probably in 2004, 2005, 2007. And we thought that we were dealing with very, very new cutting-edge technology, and this thing has been now almost available for 2 decades. So interesting that aspect of this technology. The workflow, again, is simple, and remember, in dentistry, everything is about understanding workflow. We have to design a marker and custom fit the marker. Then we bring the patient into scanning. We plan what we are going to do, and we can plan the position of the implants, angulation, size, width, shape. We can trace our nerve. We can create virtual crowns. So many things that we can do. The software is super easy, and we can go into the surgical aspect. The fiducial appliance basically is a thermoplastic material that you put in hot water and you shape it. Then you try it in the mouth, you make sure that it doesn't move and that it have good fit, and then the patient is ready to be scanned. The scan process is done. We check for precision. We check that there was no movement. We verify the fiducial alignments, and we get into the computer planning process. And this process starts by the importing of the data, tracing of the nerve. If you're working on the lower teeth, you can create virtual teeth to look at the 3D sizes that you're going to be having to be able to actually locate the positions where you intend to put your implants, to decide if you need to graft or not, and to plan the process from A to Z. And then you add your implants and you select shapes, sizes, angulations, widths. This is what is called the optical tracking devices. This is the one that goes in the mouth and it's going to have some black and white marks. And these are other devices that are utilized basically for calibration, the assembly of the handpiece. And I have the tendency of using cheap tape. There is a specialized tape that should be used. I always forget to get it and I grab what I find first. It works. And you go into the navigation process. The navigation process starts with the calibration of the drill axis, which is putting your handpiece into this little tip over here and rotating. It happens very fast. The software have been improved dramatically in the last several months. And then you go into the drill tip calibration by placing the tip at this area where there is a little dimple. And again, it's a process like every single process. You had to go through learning how to wax up, and it was frustrating. You had to go through the process of doing preps in plastic teeth and then in dental teeth, in teeth actually. And now you have to go through the process of adjusting yourself to work upside down in reverse mode in the 3D environment, looking at a computer rather than looking at the patient, which can be a little painful. Then, basically, you are doing your dentistry, everyday dentistry, everyday surgery. This device will give you the area where you have to drill and the angulations and depth, that's it. But it doesn't do surgery for you. And I'm actually honored to have this slide here because basically we have the person that created this technology, Dr. Shokron. You are sitting back there. Stand up for me, please. Thank you for developing this technology. So we are big fanatics of utilizing PRF whenever we can put it in our surgical site because it helps with the healing of the sites, soft tissues. And this is a work that was part of the original work that we did back in Colombia before the FDA approved this technology. And this is Dr. Francisco Donado in Barranquilla, who was able to shared side mill these crowns for these implants. He did a nice job, and you can see the fact that I was telling you that if you don't spend time in staining, glazing, crystallization, it's hard to get beautiful shades, and you get pretty much a blonde matte finish in the crowns. And this is the part that sometimes bothers me about digital technologies and milling in your office, because if you don't have somebody dedicated specifically for the shading and giving life to this ceramic, the life is going to be so limited. And the whole idea is that we incorporate technologies that are going to make us better and going to make more beautiful work. So we need to have somebody to help us with this part because it takes time. So if you are milling in your office, remember, you have to spend some time in the glazing and stain. So originally, we started trying this machine overseas in Cartagena with Dr. Vélez in his practice. Dr. Bassan Rabi came from Egypt. Francisco Casadesus came from Venezuela. And we did several cases in a very relaxed environment. Cartagena is in the beach. So the first case was a lady that had a car accident and she lost several teeth and had several damage. So we went ahead, went through the planning process, did the calibration process, calibration test, pilot osteotomy. You always have to make sure that you test the position of the bear to make sure that the calibration is done properly. And you go into the process of doing the osteotomy, and if you have to do any type of grafting or whatever, you do it. You do your surgery as you always do. This patient had fractures, all kinds of endodontic problems, and it was all addressed by Dr. Vélez. We left the country, and Dr. Vélez finished the cases. We did probably 100 cases in the process of creating the FDA cases. And Dr. Vélez is a very well-known speaker in Latin America who happened to be working with many of the new planning cosmetic softwares. So he went through the process of doing everything by the book. Nice clean case. He's into digital technology, so he scanned the case and did the case fully digital, utilizing custom zirconia abutments, utilizing PMMA temporary crowns, and did some beautiful final crowns. A little recession, the patient wasn't very clean. It was a big problem because every time she went to the office, went full of plaque. But look at this, beautiful facial table, very stable, very nice, about 2 millimeters by the book. Nice job by Dr. Velez. One of the most complicated parts of this technology have been to make the incorporation of this technology and make it work in fully edentulous cases. This has been the big headache, and we have been working not only with Naviden but with the other companies in trying to make it more simple and easier. So this is what's going on right now. This is a patient from Nicaragua who happened to be a very humble lady who works in the house of a friend. This is a pro bono case, and this is considered a Declan Lake aesthetics. And it happens the same in Colombia, in my country. The peasants, when they turn 14 or 15, they go to a dental practice to request that you extract 3 or 4 teeth to get their partials, their flippers. And you go like, hey, these teeth are completely healthy. They say, no, you have to extract them, and you have to extract them and put the flippers. And that is a process of growing up. It's some type of tradition. So this lady had that done, and she also had these fenestrated inlays placed in those plastic teeth. But she said, like, doctor, I don't want to have this anymore. I want to have new dentures, and hopefully the dentures are not going to move. And we needed people to do several edentulous cases very quickly, so we invited her to come along. And one of the important things, and I want you to follow this carefully, is that, remember I told you that every time that you calibrate the burrs, you have to make sure that the calibration is precise. So in an edentulous patient, you don't have anything to check and test the calibration. So one of the procedures that we're doing to check and test the calibration is utilizing tenting screws that we're placing in the posterior area. And now this device is going to be the testing device, because you're going to scan the patient with this device in place. So basically, now you have a device that you can utilize to test your calibration. Number one improvement in the protocol that we did. So we go into a crestal incision, open a flap, level the bone, try to get some of the more basal bone that is a little wider, and we start with the insertion of a mini implant. And we look for very, very good stability in this mini implant, the standard insertion mini implant protocol that you already know. Then we place the mini implant. Now we have achieved good primary stability, and we're going to place the Navi stent. And this Navi stent has a little device here that have the same shape of this mini implant anti-rotational component, and we are going to get it tight with a Allen screw. Allen screw. So now we have mounted the Navi stent, and we have secured this screw, and now this device is not moving. You have to make sure that there's no movement. Movement means error. The patient is ready now for the combing CT, and it's scanned. We go into the reconstruction, we check that there's no movement, and we are going to perform now the plan. So we decided that we were going to place 4 implants for this lady. We check the lengths, we check the diameters, angulations, and we start the process of placing these implants. You can see here the area that we had to remove in the beginning to kind of standardize the reach. And we start the process of calibration of the drill and calibration of the burr, as I mentioned to you before. So we do the initial osteotomy, place our paralleling pins, and you can see that it looks very, very nice, very even, very well located. So it's a technology that gives you beautiful implant placement, beautiful precision, 100% control of your osteotomy. Now the implants are being placed, and we decided to put ball attachments. Remember, it's a patient that is getting a pro bono job, so we were not going to get into fixed positions. We were testing the technology and giving this lady an option to improve her quality of life, talk better, and eat better. So it was a win-win situation. Patient now goes home super happy. We're doing the female pickups. But then one of the things that we did when we tried to apply this same technology in the maxilla was that we were not getting good mini implant stability, because we know the difference in bone quality from the mandible to the maxilla. So the first question that we had was, how can we improve mini implant stability? Problem number one to resolve during the protocol creation. Problem number two is, how do I perform prosthetic management? Because if we're doing big cases and we're going into fixed cases, we want to have some type of prosthesis already done before the surgical case is done. So this next case is going to address that part. And the third part is, how do we make this technology communicate with other digital technologies? So this case was a modification for the maxillary protocol in a fully edentulous patient, and we decided to do what we like to call bicortical mini implant stabilization. Instead of placing the mini implant vertically, we decided to put the mini implant horizontally. So that way we would strike the facial table and we would strike the palatal table. The objective for this specific case was to address in a single case several clinical problems and several dilemmas that we were having with this technology. Number one, we needed to test the possibility and the viability of importing STL files into this type of technology. Then we wanted to see if we could integrate optical scanning, the model that you make with your tree shape or with any of the intraoral or extraoral scanners, with an implant plan that you have already prefabricated in a different software. Why? Why? Because if you take a scan and you place some implants in a scan and you add in that implant planning software some abutments, you can now export that data, print that data, and you can have your technology fabricate a prosthesis for you, utilizing the standard articulator mount technology. Or you can even do it digitally. But you needed somehow to communicate. But then the next problem was, once I have done that, how do I place the implant in this type of software in the same position that I need so the two works fit? And that's what this case is about. So we started by utilizing, again, tentin screws. And we placed 3 different tentin screws because we were going to do an optical scan, but we also needed screws to verify the actual position of the calibration. The second thing that we did was the horizontal pilot osteotomy for the mini implant. The mini implant was placed horizontally. The number 3 was placing the navi stent. So now we are ready to work. Navi stent is secured in place. Patient is ready to be scanned. Optical scan of the patient is made. And again, you can use any technology that you want. And now you see that in that optical scan, you have the tentin screws. And this is basically your transfer landmarks. So you can communicate now between the virtual world and the clinical world. Always virtual world, clinical world. Now, in the implant planning software, we proceed to place some implants in whatever position, situation, location, diameter, lengths that you want. You place abutments because you want to have prosthetic options. And once you place those abutments, what you want to do now is export this data, convert it into an STL, and you can print or you can digitally start working. And I'm going to show you 3 or 4 different ways to utilize this data in your practice to make a case possible. So these are the prosthetic options that I found easy to make. Number 1, you can take that image that I show you, convert it into an STL, send it to any 3D printer, and you're going to have the abutments printed in relationship to the soft tissues. Your lab technician can take a bite registration, a lower alginate impression, mounted on an articulator, build any kind of restorative solution that you want. Number 2, you can utilize a software. There are many software now available like DWOS for dental wings, and you can create a virtual temporary prosthesis and again, mill or print or do whatever you need to make. Number 3, you can even do a dual scan. You may remember how to dual scan is a basic technology that we utilize one of the basic, more utilized technology that we use in convincity strategies. And you can also print it, you can mill it today, and it can be articulated, and it can be utilized also to fabricate a prosthetic solution. And number 4, you can utilize the classic open tray impression technique, take it as a backup, and have the technician work for you. As you see, we did it minimally invasive tissue punch technique, and we were able to develop 3 different strategies, and the 3 of them fit well, including a PMMA bridge that also fit very well. Now, this is an STL of the original plan that we had done with the interactive software. It's exported into Navident because Navident can accept optical scans, and that's one of my big inspirations. How are you doing, Dr. Gans? Very happy to see you here. So now, we have imported this image into the Navident, and remember that we had planned these implants, and what we're going to do now is a correlation. We're going to take with the Navident device, and we're going to put the implants exactly in the same position that we're seeing here. And this is what we see. What we see in yellow is the Navident implant being correlated to the implants that we had already planned in the interactive software. And now we have been able to correlate 6 implants exactly in the same height, same position, same angulation, and we have a duplicate of the original plan. Patient is ready for surgery. Calibrate the handpiece, calibrate the drills, and now we're looking at the computer. We go through the process of doing the sequential osteotomy. You can see that it's very, very precise, very easy to get into target. And as you change the burst, you get closer to the target because you are able to fix and compensate for whatever missing of the angulation, depth, or position. Implant is calibrated, implant in position, and we have placed 6 implants, and this patient is now ready to get a temporary solution. Super minimally invasive case, very nice looking, very happy that I was able to get it. This is the post-surgical convincity segmentation, looking exactly as planned, overimposure of the plan and the performance of the case, final result. And what you see now is the reconstruction of the STL, and the patient goes home super happy. Another pro bono case, very humble guy, a handyman that is super poor. In Miami, they don't make as much money as around here. So good social work as well. And the last part to finish is the advances that we're doing now, utilizing other technologies, especially in piezosurgery. In piezosurgery, you can calibrate your piezosurgery device, placing one of these devices into the handpiece of the piezosurgery. The only difference that you're basically getting is that instead of getting all that target point, you're going to get a blue arrow. And the blue arrow is going to indicate where you are, and it's going to give you the indications in the different convincity areas. Sagittal, coronal, axial. You're going to be able to see it everywhere. The indications for piezo use in your practices could be implant site preparation. We know that we can do ultra osseointegration utilizing piezo tips, ridge split, super handy in ridge split, bone reduction, sinus surgery. You can use it for lateral sinus surgery and crestal. It's really nice. You pinpoint the areas, really neat. Apicoectomies, osteotomies, harvesting of bone blocks, and extractions. In conclusion, basically, we see major similarities between utilizing a 3D printed static guide for fully edentulous patient or utilizing a fully edentulous Navi stent. Because basically, at the end of the day, what you are doing is, in this case, in a standard computer-guided surgery, you're navigating through this little chimney, utilizing this as a guide to get to this type of result, or you are having a virtual chimney, a virtual target to get to the same result. One is virtual, one is physical. They both give you the same. In my future wish list, what I would like to see in this technology is the ability of creating STLs with the software, which is from what I've been told happening, that I could export STLs directly from one of these machines' software, that I could do more than one STL imports. I can only do one at this point. That I could have in the software not only the ability to create implants and to create virtual crowns, but also to create abutments. I would like the software to enhance the checkmark detection, which has been within the last month, in the last upgrade, super upgraded. It's super fast now. And I want the optical tracking devices to get smaller. With this, I thank you for your attention, and God bless you.